Thanks for joining this panel about public health use cases for WISHIN and how that's increasingly a use case that we've been seeing across the community. So thanks again. And just to start, I just want to give a quick thanks to Cloudticity as our sponsor for this breakout session. Since 2011, Cloudticity has focused on improving patient outcomes and building cloud infrastructure for the healthcare industry. Their expert cloud engineers have spearheaded projects like the first cloud-based health information exchange on AWS, as well as the first FISMA high deployment on AWS GovCloud. Powered by their proprietary Oxygen platform, they provide the tools, expertise, processes needed to ensure security, compliance, and cloud maturity. So big thanks to Cloudticity for their sponsorship and support today. With that out of the way, I think I will just start with a paper I read back in February of this year that was kind of a reflection on COVID, among other things. And it was in the American Journal of Public Health, really talking about the nationwide health data ecosystem. And a couple of things that I thought were relevant for this group were just that COVID highlighted the lack of infrastructure in collecting, sharing health data, especially in the public health sector for public health and pop health use cases. Also, just a general need to modernize and invest in the US healthcare data ecosystem. And I'm biased at WISHIN, so I'll admit it, but this third bullet really stood out to me about state health information exchange's role and playing an important role, especially with the local engagement and knowledge that we have of our community, rather than a national player who might not know what's going on the ground in southeastern or northwestern Wisconsin. And then that there's more opportunity to leverage public health use cases for HIEs, including disease surveillance, population health, and then that interoperability and care coordination also results in staff savings. We talk about banning the fax machine. I hope you all grab a sticker on that, but I think there's a lot of opportunities with lean public health budgets to extend our staff. With that, I'm going to introduce our panelists. We are last minute. Carrie, our last panelist, got sick, public health issue, and so we wanted to quarantine her, and so she's not here today. But I'm really excited to introduce Caitlyn and Katie, and I'll have you both introduce yourselves, maybe with your name, a little bit about your professional background, and then your position, and also your role at the health department. Thank you both, and thanks everyone for being here.
Hi, everybody. My name is Caitlyn Stockhausen. I'm currently a disease intervention specialist coordinator at the City of Milwaukee Health Department. I have been at the health department for a total of about a little over 5 years. I was on, I kind of took a break when I went to Detroit for a couple years and came back right during COVID. I've done work in mostly the sexual and reproductive health, working on STI case follow-up, primarily with that syphilis and HIV. And I've been a coordinator for the last 2 years, and I just graduated with my MPH in epidemiology.
Congrats.
My name is Katie Lepak. My professional journey is that I was a local public health officer in the Milwaukee area for 6 years. During COVID, I took a position coordinating across Milwaukee County. So Milwaukee County is unique in that it has 4 health systems, 5 federally qualified health centers, and 11 unique local health departments. And so leaders in the area said, particularly during COVID, we need somebody to do some cross-coordination. So I was in that role. And then I recently joined the Wisconsin Cancer Collaborative. My role there is specific to data and evaluation. So really excited to be here today and to talk through this public health WISHIN connection. Particularly, I hope we get to the end of the conversation where we can sort of be aspirational and dream about the potential of WISHIN and its use case to really help public health.
Thank you both for being here. So I think my first question would just be, maybe I'll start with you, Caitlyn. What are some of the current ways that you're using WISHIN in your day-to-day public health activities?
Yeah, I was thinking about this, and I think there's a pretty clear delineation of like a pre-WISHIN and a post-WISHIN in terms of our public health follow-up. It's really totally been a game changer. It did coincide with the COVID pandemic, and also we moved from literally a DOS-based electronic health system where you could not use a mouse to now we can use mice. So there's a lot of changes that happen, but WISHIN, for our perspective, has changed so much. the first part of our process, whenever we get assigned a new infection to follow up on, is to do a record search. And we're looking for prior labs to clarify the diagnosis, any signs or symptoms, because oftentimes symptoms are misdiagnosed, understandably. We're looking for like the testing history for other sexually transmitted infections. And we're also looking for where is this person seeking care. So with all of those things previously, we had nothing really to go off of. We maybe had a lab, we maybe had a provider, we maybe had a previous sexually transmitted infection to look at and get some clues from. But most of it was just making a ton of phone calls, waiting for a call back, playing phone tag and hoping for the best. So it was just kind of like a lot of wasted time. But with WISHIN, we've been able to even avoid those phone calls because a lot of the information's already there. There's a lot of treatment that's already there. We can avoid those phone calls. We're finding symptoms that may have been missed, which is very common with syphilis, if anybody's ever knows anything about syphilis. And so that actually totally changes the diagnosis. And with that change in diagnosis, that changes the treatment. So we're having less people being overtreated now. So it's just completely changed our whole process and flow. And it's pretty much the first thing we go to right after getting a case.
Caitlyn, would you elaborate on the overtreatment piece? Because that was something I'd never considered that I thought was really interesting.
Yeah, syphilis, I could talk about it all day, unfortunately, but it is such they call it the great imitator, great deceiver. So it's very hard to assess how long somebody has had it, and the length of the time the person has had the infection is determined, like you use that to determine how much treatment is needed. And especially that's critical when there is a penicillin shortage, and penicillin is really the only treatment for syphilis. There is an alternative, but it's not as ideal. So with that being said, essentially, unless we can confirm the time frame with a negative test, finding syphilitic symptom within last year, or finding an epidemiologic connection, so a partner that has had early syphilis, we have to treat with 3 doses of penicillin 1 week apart, which is both hard for, it's a medication, it is also getting the patient back in. We have a lot of people that are not adequately treated. So if we can avoid that, make sure that they have early syphilis by finding those criteria, they only need 1 dose. So then it's very easy to treat people. So previously, a lot of people were getting those 3 doses because we just didn't have the information. And now it's much more just 1 dose.
Thank you. Mm-hmm. I used to do a lot of work with emergency departments in Milwaukee County, and we always talked about over-testing in that environment. I see a parallel of, if you have the right information, you can get to the right level of care without going over.
Absolutely.
So you talked a little bit about how you got information before WISHIN, but it sounded like a lot of phone calls and kind of a paper chase. Were you usually able to get in touch with the right people, or was it sometimes some dead ends, maybe too?
Many dead ends. But I think even talking, we've had we've had a lot of people trained since COVID. So we have expanded our staff to like about 13 people, and people are like, I literally don't think I could do this job without WISHIN. I'm not getting paid to be here, but it just has totally changed our process and just been so much more efficient and I think led to much better care for the patient. We don't have to bother them as much, ask them all these questions about where did you go when they have way bigger things to worry about sometimes.
Well, and sometimes as I try to describe the value of WISHIN to other sectors like our health system partners, I think this is kind of a soft benefit to them of having their information in WISHIN means Caitlyn's not bothering them. Not that your statute,
no, it's true.
You have, by statute, you need to bother them,
yeah.
But this is just one less way they can just automate this.
Oh, absolutely. No, I think the providers appreciate it too.
Katie, I know you I don't think you were a direct user with Cudahy, but I know you've worked with your colleagues. Were any kind of insights for you?
Yeah, so it's kind of full circle. So we were a very early adopter at our health department. So we were amongst the first health departments to sign on. So Greg, Steve, and I were sitting in a meeting and talking about WISHIN, and we got to be one of the early adopters. And so I'll just say, you heard a very detailed explanation from Caitlyn about its use cases, but it really expands quite a ways. It can be COVID, it could be flu, it could be tuberculosis, latent TB management, active TB management. It can even be maternal health, right? So mothers who are pregnant, who need sort of maternal health care and case coordination. That's another big kind of use case that we used. And then also lead. So lead is another really good one that we would use. So just know that the use cases are far and wide. And, bless the public health staff, because it is lots of phone calls and waiting for a call back. And when we think about the burden of healthcare staff, right, you guys are rooming patients, seeing patients, doing all the things that you have to do, or actively at a bedside. And then now you have a public health person calling, and you have to answer us. WISHIN was dramatically a shift in a positive way for us. I'll just name one of the struggles for local public health departments is, just sort of, we have very narrow budgets. So how do we find room in our budget in order to be a subscriber? And then that challenge is, how do we also push the information that our team is doing back via WISHIN so that the healthcare people on the other end, you all, can see the interaction that we are doing? So over my 6 years, we never were able to push our information out, but we were always users of the information from the health systems. And it was just dramatically different. I appreciate Greg's ask around banning the fax machine. Here we are in COVID, the very early days of COVID. And how did we learn that somebody was COVID positive? From the fax machine. So we literally had to be sitting in the health department at the fax machine, making sure that it was always full of paper as these test results were coming off. And so we love Greg's quest to ban the fax machine. We still have some work to do in that space. But those are definitely some ways that we have used it. And are really grateful for the opportunity to be connected at a local public health level to this platform.
Thank you. Caitlyn, this wasn't on the question list, but I'm going to ask it anyway. I was thinking about the Milwaukee Health Department is pretty unique in that you have a really full-service STI clinic. And could you talk a little bit? It sounds like you maybe do some prep for your clinicians in that clinic.
Yeah, so we do have the disease intervention specialists. We serve the whole southeastern region for syphilis, different areas for different morbidities, but we do also have a free STI clinic. It's a busy clinic, and we support them. So if they have somebody coming in, they're like, oh, I don't know, my partner tested positive for something, we help look into that. Or if they come in and they're like, I had a positive lab and it was gonorrhea, and we look into it and you're like, okay, it was actually something else. So we do that kind of background information so that we can make sure that we're testing correctly, making sure we're completing the algorithms for whatever infection is going on, and can treat them appropriately at that moment. Not overtreat, not undertreat.
Yep.
Yeah.
Right level of care.
Yeah.
And since Carrie's not here, I'm just going to speak to a couple of the things that she was going to touch on. A lot of it was, there's a statewide database called WEDS, which has positive results for infectious diseases. The problem is there's no negative results in there. So that's often equally as important of knowing who did get tested and was negative. Again, let's not duplicate tests that don't need to be done. And that often WISHIN has more detail in the lab reports than WEDS is pretty basic. So those were just kind of two things she was going to highlight. And then also this is so not sexy and not clinical, but that the demographic information she was saying, just like, what's the latest address and phone number, which given its real-time data, we often have more real-time information that you might have when you're trying to track down community members. And then in Oak Creek, they have a overdose fatality review program that looks for patterns up until that overdose, and that they've been utilizing WISHIN to really see patients' journey up to an overdose, see if there's patterns and things that they can learn from that. So just wanted to name those. Oh, and then finally, more basic stuff, but who's the primary care and who's the insurance? Again, that's a lot of phone calls. I don't even know what my exact insurance is, but that's in WISHIN, and that's really helpful. Caitlyn, back to you. We've kind of touched on this already, but any kind of general I know you weren't using during COVID, but any kind of COVID reflections on health information exchange?
Yeah. So I also was redeployed partially, and I was doing work at a COVID isolation facility for primarily unhoused people. So we had to it was just such a roundabout process of trying to get this information and get people to the right unit, to the right place, to try to prevent the spread for vulnerable populations. So going from that to being able to use WISHIN to just directly review the notes, review the labs, is just such a remarkable, ease in process for so many different parties. I feel like I'm repeating myself, but it's just been so efficient and really helpful. And I think what you were saying with the study that you were talking about is just there's such a need for less phone calls, less faxes, and more just information sharing because it saves everybody time and I think ultimately produces the best care for the population.
Thank you. Maybe a similar question of just reflections in general from COVID and health information exchange, Katie.
Yeah, I mean, COVID was such an interesting time being an active local public health official, right? Data became super important for public health and definitely exposed some gaps and opportunities in our data infrastructure systems. You think about, we were trying to understand who's hospitalized, were they on a ventilator, how long were they on a ventilator? Again, all of that is calls to staff who are actively caring for patients who have a huge burden that they're taking care of. Additionally, it's all of the contact tracing. So I think for us, you kind of mentioned this in Carrie's remarks, but as we started to really be pushed to understand data in vulnerable populations and at-risk populations, WISHIN really came to be important for that demographic tab, right? So where were you? What is your most, up-to-date phone number, address? Where do we go to knock on doors to let people know you've been exposed or you have a positive result, you need to be quarantined or isolated? So that was sort of real use case. But then again, we think about those at-risk populations, the next piece that becomes really important is sort of some of those race ethnicity indicators. Mm-hmm. And so we know that we still have lots of room to grow, to improve how we ask those questions, making sure that people don't just click buttons and bypass it, that they feel comfortable asking and answering that appropriately. But the WISHIN data was instrumental as we started to kind of pull that information, make sure that it was asked, verified it when we did interact so that we could take deeper dives and looks. And when we think about intervention or thinking about access points for vaccinations, like are we giving the people who are greatest risk vaccine access? Are we making sure that, so I would say race and ethnicity is another really important piece to that. And then lastly is sort of that insurance status piece, right? So you get that phone call from somebody who's in their home saying, gosh, I'm getting really sick. I need to go in, but I'm really worried. I don't want to go in because I don't want to call the EMS. It's going to be a really big bill. I don't have insurance. And so again, we can pull up on WISHIN, understand where they are, get them connected to care, assure them that will help them once they arrive to get to a navigator, so on and so forth. So I think, again, there's just been a lot of growth and opportunity. Would have been awesome, if we didn't have to have that fax machine in the early days, right? But as the pandemic sort of marched forward, we moved away from the fax machine, which is great. So there's a real-time success. But just really grateful for the tool, Greg.
Well, and I'll say, just to embarrass Katie for a second, it was very early in 2020 when we had a conversation and said, why can we make public health an approved use case? And so quickly got that through, and I appreciate you being a pioneer, but I just think breaking down the silos, public health is healthcare, but it's not always thought of that way. So I just think it's really exciting to see that as a growing use case across the state. We've actually seen a lot of public sector growth, kind of health related. So, EMS, corrections, adult disability resource centers, even WIC agencies and behavioral health. So I really love seeing the public side of our healthcare delivery system more and more engaged. So I'm going to shift gears a little bit to talk a little bit more about aspirational, like a wish list of a WISHIN list, maybe, as well as maybe some future directions. But before I do, Any questions you'd like to give to the panelists about current public health use cases and uses? Please.
How many of our public health departments in the state of Wisconsin are signed on to WISHIN?
Yep, it's about 13, and by about 13. It's a little bit funky. As Katie mentioned, she had the pleasure of trying to coordinate the 11, count them 11 local health departments in Milwaukee County alone. So it's not always at the county level. So I'd say of those, I think 6 are in Milwaukee, and then the other 5 are throughout the state. Fond du Lac, Winnebago, Dane, and there's a couple others, but I could get...
Mainly on the east side.
Correct. And at the risk of, well, I'll just say it. I think there can be a have and have-nots for local public health. You know, some just have bigger budgets because they have bigger populations. And so what I've seen is it's kind of the larger population centers are the ones that can have an easier way to make it affordable. And
Yeah, I can hear that, and I see that. It's just, I think of the rural aspects, the further you go north, and the budgets are smaller, but the need is great.
For
because
sure.
they're spread out that much further, so
Yep.
it'd be interesting.
I'll say, unrelated but related, about a year ago, DHS had an amazing pilot where they offered to pay for all adult disability resource centers across the state to have access. That's a county-based service. The WISHIN use case for them is a benefit determination. You know, if there's certain diagnoses, stuff like that. We have 50 of the 72 ADRCs on. And so it really made me feel like that affordability was a barrier. And we're not for profit, but we have to keep our lights on. It's a tough balance, but I would love to get to a place where we could figure out how to have every local public health across the state have access. Matthew?
Along those lines, so you talked a little bit about the bidirectional versus, one way. Of those health departments, how many are bidirectional, how many are just getting data?
They are all just impulse. Correct. And I think that would be a natural next step. We'll talk about it a little bit more later too, but even, we know where people live. Could we even push information to a municipality of this was a salmonella case in your community, or, is there a way we could do that even without sharing? But I would love to get to a place where some of those lab results, I'll talk about it a little bit more later, Matthew, but linking our database to WEDS, which is that state, database, or even a better linkage to the Wisconsin Immunization Registry, I think are 2 ways. Maybe it doesn't, I would love to get municipal data, but maybe targeting the DHS kind of statewide DPH databases might be another approach too. So, any other questions, or we'll kind of move to the more, please.
I'm just wondering, with all the data you have, is WISHIN or someone analyzing all of that data to push it out? Is it, making it, because data is super important, right? So are we utilizing that information in a beneficial way?
And I think that's exactly where we're going. So that's a great segue. I will say, I feel like I've got to pay a lot of people after this one, but thank you, that's great. And I'll say, currently, population health and analytics is not a current use case, but we're working up an amendment that will go to the board to get that approved as a use case for population health and analytics purposes. So that is the natural next step, I think. So Caitlyn, as putting you back on the spot,
I am.
what kind of other clinical information, what would be on your WISHIN list?
Yeah, no, I think to the point that was brought up before, I would love for us to be able to put our information. I mean, so that's not a WISHIN thing. That's more of a our side thing, because I think because we do a lot of communication and providers do call us to be like, hey, has this person been treated? Have they, so that would reduce phone calls and improve quality of care and reliability of information as well. Because I think in clinical care, you have to go by a patient report sometimes, but it would be nice to be able to back that up. So I think that on our end, that's a dream of mine to be able to input that information. Yes. I mean, I've loved the addition of the notes. That was another thing I was thinking about, because now we can see some provider notes. And I think that has just improved the, the prevented miscommunications. So, you can talk to somebody, they're in a rush. They heard something I didn't mean to say, and the wrong test gets ordered. and it's a repeat test of what was already done. So I think being able to directly read the notes instead of having a middleman has also, I think, improved patient care in that way as well. One of my little dreams is to have a filter a little bit better for to be able to filter through the information to just get what you're looking for, because I love the additional of information, but can be a lot to sort through sometimes. And then the federally qualified health center participation, because we work with them a lot, and that's just one of the groups that I think has not been able to incorporate data into there, and they're they're very overtaxed, and so sometimes very difficult to reach. I think another thing was like seeing whether somebody actually made it to their appointment. So we can see sometimes appointments are there, but we don't know if they actually accomplished that appointment. And so that I think that would be really helpful. And then I think I just added this one to my list, like having a preview of the documents instead of having to download everything.
Interesting.
That's my little WISHIN wish list.
I love it. And just maybe 2 quick follow-ups. Notes are what we call technically in WISHIN to be transcription. So everything from discharge summaries, histories and physicals, that is increasing. Laura this morning talked about how I think by the end of the year, at least in the Milwaukee market, all of those 4 health systems will be sharing transcription data. So that's really exciting. You'll be seeing more of that. And then we don't currently have appointment data. So like a show, no show, that is on our roadmap as well, because I think what I've heard from public health, from payers, from several is, I would love to know when a patient doesn't show so that we can re-engage for next steps. So thank you for those. Katie, you're sitting in a different place. Maybe you could just give a soundbite or 2 about the Wisconsin Cancer Collaborative, and then maybe some of your thoughts that I think really help with some of the, tie together back to some of the questions from the audience.
Yeah, so the Wisconsin Cancer Collaborative, we invite all of you to become members. It's free to join. We have a conference coming up, so if you're interested in coming to our conference, please join us. But we are a statewide coalition of organizations working together to reduce the burden of cancer for everybody in Wisconsin. We kind of have 2 bodies of work, so it's the coalition work, but then we are also the state's comprehensive cancer control program. So the Wisconsin Department of Health Services receives funding that comes over to the Wisconsin Cancer Collaborative. As a part of that work, we have a comprehensive plan. It's a 10-year plan, 2020 to 2030, that outlines several different chapters, everything from prevention, screening, diagnosis, treatment, through end of life and survivorship. So we have all of those different ongoing buckets of work. And so my specific role that I'm working within the collaborative is related to data and evaluation. And so in this role, we think about the breadth of data that is potentially available in the treasure trove of WISHIN. And then we look at sort of the data that we have available now. So the majority of the data that we have available now is phone survey data. Well, how many of you answer a phone call these days when you don't know who's calling? How many of us have landlines versus cell phones? When you actually answer and you get somebody and they're willing to take the survey questions, how many people accurately remember, gosh, did I have a mammogram this year? Did I have a colonoscopy this year? I don't really know. Was I ever told that I have cancer? Well, I went to the dermatologist and they had that spot and I think it was, So we have all this survey data. That survey data, for all the reasons we just described, can be a bit of a challenge. And then there's a big time delay. By the time that data is collected to the time that data is published, there's usually a 3-year delay. So when we want to talk to partners about what does screening look like, what does treatment look like, what does diagnoses look like, where should we be helping you prioritize evidence-based interventions, we're doing it with data that's 3 or more years old. So that's a pretty big limitation. Cancer, doesn't always happen in the same place, right? So then we have to think about small numbers and how do we protect people's identity? And then we're lumping, things over 5 years of time and can only report it in 5-year increments rather than annually. And then a lot of people want that really geographic specific data. Tell me about my county where I'm working. Tell me about which zip code. Tell me about which census tract. And that data is just not currently available. One of the biggest gaps we think about right now is really in the screening space. So a lot of you who are within health systems are thinking about this in your health system already. How do you use your own EMR to understand cancer screening data? The bigger question is, of everybody who's in my EMR, how many are eligible for a particular cancer screening, whether it's female breast, cervical, prostate, colorectal? I mean, that can be pretty challenging to figure out. And so this is when we really came to our friends at WISHIN and said, we want to dream with you because you have this huge representative population, and could you be the eyes and ears in a more real-time fashion, particularly for cancer screening data? So we are in a very early exploratory process with WISHIN to develop and implement really under the lens of quality improvement related to statewide cancer-related population level data. And so a piece of what we do is run community of practices. So one of our colleagues who's not here today runs a really awesome community of practice around survivorships. And there's numerous health systems across the state of Wisconsin who are participating. Among those health systems, there's over 30 quality improvement projects happening in the space of survivorship to really help move that needle. So again, how could we leverage WISHIN to understand this gap of what we don't know? And then, coordinate our collaborative, our health system partners, other folks who are doing this work to really help us move that needle in a QI lens. So we are super excited to be thinking about this, thinking about how would you define a variable, who would be eligible, how would we even do this? And we have colleagues in other areas of the state, not specific to cancer, where we've seen this. So I have a colleague in the room, Alice and Antoine. And Maryland, for example, their health information exchange flags when an individual's trending up for their hemoglobin A1C. And it's identifying them when they're sort of pre-diabetic. And then it will automatically enroll them in a program and link them to care before they turn truly diabetic. And so we think about where we sit, which is in the DHS Chronic Disease Prevention Bureau. And we have so many colleagues from Well Women to nutrition and health to diabetes to you name it, who are so excited that we are on this exploratory phase and are dreaming about sort of how do we build this system, right, so that it's easy to accept these incoming asks to understand what the data might look like. So we're excited to dream about this with you guys.
Thank you. We are too. Any other future directions or wish list items that come to mind?
Going back maybe to Cheryl's comment, I just can never give up my government public health friends and just continue to be an advocate for them. Cheryl, particularly our friends in the rural area where you are far and wide and care is, just looks different for lots of different reasons. So how could we come together and think about access for local public health departments statewide in a way that would really be a quality improvement, that would be a lift for all of our healthcare partners, right? We wouldn't have the fax machine, we wouldn't have the phone calls. And then the phone calls that are coming, that they're gonna be really meaningful. And maybe going back to what Matt said is, how do we overcome that barrier of the bi-directional push, right? Because now if you've made it easier for local public health, but now all of a sudden they're like, well, I talked to that nurse at the health department, but you guys can't see it on the healthcare side. So I just see great potential in that space and think that there's a lot of really great minds out there, and we could come together in a really unique way to problem solve some of that.
Thank you.
Especially being prepared for our next public health emergency, all these other areas.
Yep.
Everything. I mean, it's a lot. I was looking at your thing with the ADRC. I'm very impressed with that situation.
Thank you. I'm happy to talk more about it. But
Yeah, sure. But I'm just impressed with that. That's what I was looking at. I was like, wow.
please, Angela.
I'm curious what the biggest barrier to that bidirectionality is. Is it just like individual organizations or entities' ability to support like a FHIR API connection? Is it willingness?
I think it's been sophistication of electronic health records, given shoestring budgets in public health. That would be, and then some transitions of, as folks think they might have a new EHR vendor in the future, let's not start with one if we might be changing in the future. But that's been the biggest barrier. Great question.
I would just say that, to be really frank, it's just budget, right? Like, so how much was it to sign on? You know, Steve and I had conversations. I'm like, well, this is what my budget is. It's all government dollars. Like, you know, how much do I have to give you to do this? And so, he's like, here's what the number is, and we made it happen. But then that bidirectional piece, it's not in there. It's not in there to do it. It's not a lack of desire. So again, I think, you know, as a state, right, like, how do we do this differently, particularly in a time when our workforce is so challenged, right? We are down workforce, we are burned out, we are seeing turnover, we're not having new recruitment, we're not retaining well. So how do we leverage this tool that could really make a difference as a statewide tool in this new effective way? So we'll see where we can go with that.
Love it.
I was just going to add to that. I think one of the other things is I think WISHIN has really the increased effectiveness has improved morale for our staff too, because people feel like I can be effective. I can get in this information in enough time to get this person what they need, because often some things are time sensitive. So I think it has improved morale and people's like confidence in working collaboratively with healthcare systems. Another thing I was going to say is, I think with public health, you're trying to do more with less. I hate that phrase, but that is the phrase. But I think WISHIN is one way that I was like, that is one way where you really can do more with less staff. So just a thought.
That's great. Thank you. Matthew.
Following up on that barrier to bidirectionality, I appreciate the budget conversation. Is the financial challenge, I don't think it's connecting with WISHIN. Is it having the input in the first place to connect with WISHIN, or?
Yeah, so I implemented 2 different electronic health record systems in my 6 years at our local health department. We were one of the very first to do an electronic health record. We did even had a billing revenue cycle management system, and then we pivoted to another piece. But right, so it's the annual subscription fee, but then it's what do I have to change on my internal side to have the capacity and the adequate push to share that information, and sort of what would the cost be to us as a municipality or a county to have that in place to securely push it. And that infrastructure just at that time didn't exist, and sounds like it still is not there for many of our local health departments.
To be clear, it sounds like the issues, the EHR was not capable of meeting the common standards that WISHIN has.
So it had the capability, but we would have had to pay for that service to the EHR vendor, right? So you purchase a certain scope of work, and so we would have had to purchase that, and then we just didn't have the funding to do it.
Yep. And that's kind of my impression of it is there's some nominal one-time fees for the WISHIN side to get those connections in place one time, but that the EHR vendor often has, exactly, it has an ongoing budget item. This wasn't part of your trim, you're feeding data now, extra X amount a month.
I was going to throw in there too. I think we're the example of the switching EHR. So from no mouse to mouse, and now we're switching to a different program too. So I think that was one of our barriers. I'm sure budget is also part of that issue.
Sure. Other questions, thoughts?
All right, my question is, like, where are the EHR systems in this conversation? Are they also coming to the table to talk about making all of these connections, or is it truly just with WISHIN and the health system? Like, is Epic there too, if that's the system they're using?
Yeah, we consider Epic as a partner. All our integrations with Epic systems, we work directly with them for. So we see them as a partner. I think what I've understood about some of the work Epic's doing with interoperability, Care Everywhere, if you're on Epic, Epic to Epic is a slam dunk. And I encourage you to use that. We don't want to compete with, if you can keep in there. But public health is a great example of a sector that has very little Epic access. And so I think this is a way for those other non-Epic organizations across the state to have access to information they wouldn't otherwise have. But they're certainly at the table, and we have conversations with them often. Cerner, some of the other large ones as well. Please. Get free.
Yeah, just pass all the way. Yeah.
Thanks. I'm Gabrielle Root. I'm with the Wisconsin Collaborative for Healthcare Quality, and a lot of what you're saying certainly interesting. This might be a question for Greg, but I'm curious where the other unique data sources in Wisconsin fit into this conversation. I wrote down that health systems don't know where their patient lists are, and that's what we do every day and provide it. So I thought of that. I thought of WIO, our state all-payer claims database, that also puts a lot of graphs and visualizations. We partnered with them on census tract data. So where does that fit in this space? Is this an opportunity that you're not aware of these resources and we need to do a better job? Is this different work? How are we seeing these other partners in the state as part of these really wide-ranging needs? And again, I'm with the Wisconsin Collaborative for Healthcare Quality. So anytime you say you want quality data, I'm like, that's us. But Wisconsin's really rich with WIO, the Hospital Association. I heard Matthew talk with their data. We've got a lot of data, and duplication is really, I think, as big of a problem as not knowing where to look for the data. So curious how that all fits in this work. Thanks.
Would you like to? Or I'm happy.
So I will just say we are always open and welcome to connections and conversation and ideas, right? So for us, we are a CDC-funded program. We are supposed to be doing comprehensive cancer control at a statewide level. Again, most of our members and partners would like that sub-level, zip code level data. We don't have access to data at that level, right? In most cases, because we're using BRFIS data, right? So then the BRFIS data from DHS is reported maybe at a county level. Incidence and mortality, we can maybe get it at a county level, right? We can't get it at the county level to protect that patient sort of identity. So I will just say we always welcome opportunities to learn. I will just rename. I'm very new in this role, 4 months and counting. So welcome that. But I would just say we are having conversations with other data folks, right? So there are ongoing conversations to understand, like, what are your metrics and who are your members and how are you representing data? So one of our big pieces is our performance measures for our 10-year plan. We just did a member survey. A lot of our members will use our performance measures to support their health system in their sort of process for their COC, Commission of Cancer accreditation journey. So our performance measures are, I would say, probably more valued than we realized. And so this kind of feeds back into this question of, like, how do we make sure that those are population level? How do we make sure that they're meaningful, supporting all of that? And so just having a deep dive to look at all of that. So please just know we're in conversations with WCHQ. We're in conversations with others. There's always room at the table. So if you've got ideas, please reach out to Allison or I.
Thank you. We got 4 minutes. Any last thoughts or questions? Yes, Trista.
Currently, WISHIN doesn't put future appointments in there.
Correct. That's not a feed we have right now, but it is on the roadmap. Because I think, again, seeing those no-shows could really create some action.
Krista, I will mention, sorry, I'm just jumping in. we do receive pre-admission data from some organizations. So that information would be in WISHIN Pulse. You would see, it's needle in a haystack, but how we can surface that pre-admission to say, Steve Rotman has an appointment scheduled for October 15th at some specialty clinic. We are receiving that from some organization. So if that pre-admission type of information would be helpful, not from all, but some. But that's an expansion opportunity.
Please.
I was just going to suggest maybe looking at generative AI technology to layer in with your data. So to make your job even easier, I'm thinking about, there's case notes, right? Like using generative AI to do a summary of the data on that patient record to give, a snapshot of what's going on with the patient would be, I think, super helpful and save a lot of time.
I love it because not for data modeling and predictive, but do it just for point of care in Pulse. Because I think, Caitlyn, one of the things you're saying is you love that there's so much data in there now, but shit, it's a lot of data in there.
Yeah,
now.
that's what I was, when she mentioned that, like just adding more filters, well, the technology's there. It's just educating people and implementing it. So I would suggest that as something to put on your wish list.
It's a great idea.
And happy to help.
Awesome. We'll connect after. Well, we're at time. Any last thoughts? Otherwise, we got a 10-minute break, and we'll come back to the main session for our last session. So thank you to our panelists. Caitlyn, thank you. Katie, thank you.